Welcome, everyone. I am Bob Wurzelbacher, the director of the Respect Life Office for the Archdiocese of Cincinnati, and this is our video podcast series that we call Being Pro-Life. Each month, we discuss a different topic in the Respect Life arena. We'll hear a personal story from someone deeply affected by that issue, and finally, we'll share ways that you can get involved. Today's guest is Ohio House Representative Adam Mathews. He's here to talk about Ohio House Bill 324, the Patient Protection Act. In brief, this is legislation that's designed to protect Ohioans from taking drugs that cause life-threatening effects without having first an in-person visit to give the patient a true opportunity to discuss the risks with the provider and have an in-person scheduled follow-up visit as well to ensure that they get the care that they need. So Representative Mathews, welcome to the show.
Thank you so much, Bob. Honored to be here, and thanks for all the work you're doing in the pro-life movement.
All right, well, we probably all know that the advances of telemedicine, it can be a wonderful tool, right, to give us some better access to doctors and medication when we need it. But we also know it has led to an increase in patients being given prescriptions that are known to cause a high rate of severe side effects without what most people would probably call a reasonable amount of informed consent. A follow-up visit to make sure they're doing okay, and that if they are experiencing some side effects, that they get the care that they need. Is that a decent, quick summary of why this bill is needed, or what else do you want to talk about the seriousness of this problem in Ohio?
Absolutely. And that is one of the many issues of balancing increase of access, lowering costs, making sure that people can get the medical care they need, while ensuring that they are not having unnecessary side effects, that doctors and medical professionals can actually see the person, the whole person, and have their prescriptions without harming them, fulfilling that Hippocratic oath of doing no harm. And this piece of legislation is, if there's any type of medication that is sending more than 5% of people that are getting a medication to the hospital with emergency room visits for sepsis or infections, for organ failures, or for death, that those types of medications, you need to go see a doctor beforehand and after to make sure that that is safe for you.
I was going to ask you that very question. You started to touch on that. What is the definition of serious side effect? You mentioned organ failure, death, of course. Are there other, what is the definition more specifically even than that?
So we define that within the legislation, and it is hospitalization requiring surgeries. It is infection or sepsis or hemorrhaging that requires hospitalization. So even if it's just a little bleeding from your gums, that doesn't count as serious. Or if you have medication and you get a small infection that may be unrelated or you can handle on your own, like an eye infection or something else, that doesn't count either. These are things that you are put out of commission that can easily spiral into serious, long-standing consequences. And so those organ failure and death are the ones that we call serious secondary effects here.
Right. And hemorrhaging, you mentioned pretty serious hemorrhaging is one of those as well. We come up with 5%, right? That sounds reasonable to me, but is there some kind of in your work and talking with doctors or hospitals, is there something specific about 5% that is normal for medications? Because 95%, on the other hand, that sounds offhand really good, 95% success rate. But when you think 5% really serious, that sounds really bad. So is there like a given rule about that kind of stuff?
Well, we thought this was a great place to start because normally for the FDA to approve something, it is 0.5%. Some medications do have serious side effects, but we take those as trade-offs for cancer drugs, where you are going to risk the serious hemorrhaging so that you can fight the cancer.
Right.
But even with that, you want to have consistent medical oversight.
Right. So what you said 0.5%?
0.5%. So 5 out of 1,000 instead of 5 out of 100.
Yeah, that's a gigantic difference there. Yeah, that does make sense. I don't think I would want to at least unknowingly take a medication that had 5% serious side effects without having a long conversation about what does that mean. And so, is this a growing problem, right, that we have seen already in the past 5 years, really probably, since telemedicine has really been exploding, that has caused this, or is it more we just see this as it's going to become a problem if we don't stop it sooner rather than later?
We do see that it is a problem. We have seen the rise of telemedicine, especially in the, say, mifepristone or otherwise, that even now the FDA is open for comment on saying this was too far. You saw the Ethics and Public Policy Center's survey of insurance claims showing that above the 5%, you had over 10% of women had this medication, had these types of serious adverse effects of organ failure, sepsis, serious hemorrhaging, serious infection. And we've had serious side effects here. And this type of legislation, even for that, would put it back to the standard that it had been when the FDA first approved mifepristone, which was requiring multiple in-person visits.
Right, exactly. I think most of our audience probably is aware of that, but mifepristone, you're talking about the abortion pill when it was first approved back in 2000, I guess, or it was only approved up to 7 weeks of gestation, first of all. But well, anyway, that was a big issue too, but is that you had to have an in-person visit. You had to have another visit before you could be given the medication. And then you had to have a follow-up in-person visit. And now, at least on the federal level, those are all away, and you can do it entirely with a virtual visit, even a texting visit. Virtual doesn't even have to be a camera like we're doing right now. You can actually text and get your medication with no follow-up. Now, states have different regulations on that. So that brings up my next question there. What is the current availability of the abortion pill in Ohio that this could affect?
Right now, the only restrictions are the ones that we have, the federal restrictions. We have had bans on telemedicine for these, but those are on hold currently because they were directed just towards the abortion pill. However, this type of legislation is generally applicable. As I mentioned before, it would be for cancer, it could be for anxiety medications, it could be for really anything that has a 1 in 20 shot of sending you to the hospital with something serious. And so this would put that back there, where right now we are waiting to see what Article 22 does as it works its way through the courts, as people challenge the very reasonable regulations that we had in place on the abortion pill and telemedicine.
Right. So was it issue 1 2 years ago, a year and a half ago, that made the abortion pill even more accessible in the state of Ohio?
Yes. So from there, Hamilton County Common Pleas Judge Allison Hathaway, she put in an order prohibiting medical providers from prescribing versus telemedicine and all the other types of blocks that have put in there, the 24-hour waiting period, and any type of regulation that we had put in. We've had local judges put in statewide injunctions on this, and we are waiting as our Attorney General and others appeal it, because we know that these laws were duly enacted. We're there to protect that balancing act of states' interest in saving the baby, as well as provide standard health regulations that would be reasonable in just about any other situations.
Right. Reasonable protections for the mother, even anybody who's going to put any kind of medication or chemicals in their body. But right now then, which is not quite the same case as 2 years ago, but right now in the state of Ohio, you can get the abortion pills sent to your pharmacy or directly mailed to your house through a telemedicine appointment in the state of Ohio.
That is correct.
Right. Well, what are some of the other situations happening that you know of specifically in telemedicine in Ohio that this is going to help address?
So we want to make sure that as telemedicine becomes more common, as you mentioned, you can text and request medications, that if it is for anxiety, depression medicine that may have side effects of suicidal ideation, we want to make sure that you go see a real person to have that conversation. And Ohio is able to, and we saw that in the Scrimeti case at the Supreme Court of the United States, states are allowed to provide better protection for their citizens than even the federal baseline. And so as we continue to go that way, we are making sure that telemedicine continues to be available, but for the very dangerous medications, that you have the type of standard of care where a doctor sees you before and checks up on you after, rather than it getting mailed to you without that oversight.
To me, just in general, that just sounds like common sense. Are there other states that are already have done something similar to this, or Ohio leading, in this department, or where are we nationwide?
We have seen some states, Louisiana was able to go even further, specifically on the abortion pill by saying it's a controlled substance. We are leading, and we're looking at other states and seeing risks that are happening there. There was one state I heard from some of my colleagues that a boyfriend used an ID for his girlfriend, used the telemedicine to get the prescription for the abortion pill, and then ordered it that way. She wasn't requesting it, it was him, and used that, and depending on the circumstances, allegedly coerced, pressured for her to take that abortion pill. That's not the purpose of telemedicine. And we see these things happening throughout the country. And having the type of safeguards of in-person is going to help those types of situations.
Right. I don't know how all this works in terms of physician's assistant, other types of medical professionals that are able to prescribe drugs of any sort. But I know that as far as the abortion pill is concerned, that has changed from being required to be a physician to not being required to be a physician necessarily. Does this bill in any way address whether you have to be an MD or a physician's assistant or those types of things to prescribe certain kinds of drugs?
For the prescription, we don't touch that, but to have you still need the in-person doctor's visit.
All right. So Adam, it's almost astounding to me. And I've done a lot of podcasts, right? But this legislation is so simple. I feel like we've covered it pretty well in such a short amount of time. It's pretty common sense. It's just saying, hey, if there is medication that has a high level of side effects, and 5% is, as you mentioned.
Normally, when the FDA approves some type of medication, if it's over 0.5% or 5 out of 1,000 people are going to have some serious adverse effects, it's going to take a lot for the FDA to approve that medication. So what we say is something that's 10 times the standard going rate for the FDA approval. We're not messing with the approval. We're just saying you have to go and have a doctor check you first, before and after. And especially, you've been asking before about the mifepristone. One of the really dangerous situations could be a woman that has an ectopic pregnancy and then tries to take mifepristone. There can be severe, dangerous hemorrhaging there that can lead to organ failure and death. Right. And so we want to make sure that in all these situations, at the very least, go have a doctor check before and after.
Right. It's basic patient safety here that we're talking about. So what's the product? Let's go over that real quickly, right? When was it introduced? How long does it typically take? Is it in this early stage? Do you have an idea of how much support there is, on both sides of the aisle for this? And what are your thoughts about the timeline for this?
Yes, we introduced this. Representative Meredith Craig and I introduced this right before we finished out the budget. So this was in the May and June timeframe. And we had our first hearing already. The Republicans in the Health Committee seem overwhelmingly supportive. The chair is local Catholic Representative Gene Schmidt, who seems very favorable towards this. And so I believe when we come back from the time right now where we're all going to the state and county fairs and being back in our district, when we come back in October, I would expect that we can move this piece of legislation. It's common sense while also standing for moms and babies.
Right, exactly. Well, if you want to learn more about it, obviously this is both a podcast and a video cast. So now you can see on the screen, if you go into your search bar and you just search Ohio HB 324, and then make sure that you go to the 2526 session, because the same bill number did have something else in a previous year. But you'll see it here, the Patient Protection Act. You can see Adam Mathews and Meredith Craig are the sponsors, and you can read the whole thing if you'd like and get more information on, but it's pretty simple, but you can get more information that way. I suspect we're not yet at a point where we'll be asking, or are we, where we'd be asking people to call their representatives and tell them to vote for it? Is it a little too early to do that? Or never too early?
It's a little early right now, and I believe all of our Republicans down here in Cincinnati are going to be supportive. And so calling and say, please vote for it, but also saying thanks is greatly appreciated.
You search for your Ohio legislature on that website, take it to the website, you type in your zip code, and you can find your legislature. If you don't already happen to know who that person is, then it's easy to contact that person and encourage him or her to vote for this legislation. Once it gets further along, though, as always, our office will be a little bit more intent on saying, okay, this is a good time to call and talk to your representative about this. So, Adam, what else is going on, perhaps, that the listeners here on the Pro-Life podcast would like to hear about that you're doing there at the legislature?
We are working to see what we can do from the second order effects of the One Big Beautiful Bill passing, where the Planned Parenthood was defunded for a year.
Right.
And it's supposed to be a partnership between the federal government and the states for Medicaid. So if there's something we can do here in Ohio on that, we are evaluating that right now as well. And then we are following up with a case that I appeared as a amicus brief writer for Kerr and Medina versus Planned Parenthood South Atlantic to see what we can do for Medicaid funding to protect Ohio's taxpayers from funding anything that they do not believe in. And we've already had in the past legislation that prevents any taxpayer dollars from going to abortion providers. That continues to be on the books. They haven't challenged that yet in the courts. But looking from the precedent that is there in the Kerr and Medina versus Planned Parenthood South Atlantic, you can go after the entities in total and not just for their abortion providing services, but for them getting taxpayer dollars and Medicaid dollars anywhere. So we're looking at all of these options right here to further bolster what we know is good, what we know is true and beautiful, and using this continuous support that we've had on the federal level, clearing the way, bring that here to Ohio.
So here in Ohio right now, can Medicaid state dollars go toward Planned Parenthood services?
Currently, Medicaid dollars cannot go to their Planned Parenthood's abortion services, but they potentially could be used for other generic services doing other things.
Anything else that you want to talk about that might be of interest to the listeners, or maybe even just about you, what you're doing outside of the legislature?
Sure. So pro-life starts at home. Married to my beautiful wife, Amanda. We've got 5 kids, 11 down to 1. That's good. My day job is I'm counsel with Heartbeat International, where we do support for the pregnancy centers throughout the country. That's been great work. I was very grateful that our budget included a tax deduction for donating to pregnancy centers and returning homes. And that's going to be great as we continue that way. Not a credit like our scholarship granting institutions where you can give, $500 to your local Catholic high school and get $500 off of your state taxes. This is, if you gave $500, then it's like you made $500 less, right, and you're taxed accordingly.
Is that a bill that I know that's been talked about, though? Is that something that's going to be in this current year, even something that somebody's trying to push to do that dollar for dollar related to pregnancy care centers?
We are going to continue to work on that to make it dollar to dollar rather than affecting your taxable income. And it's a lot easier now to move a deduction to a credit than to move from nothing in to become a credit. So we are going to continue to work on that. And I would expect a good solid push for that for the next budget for the next term.
Sorry, I just got to get a little clarification on that one. But anything else? You were starting to talk about so many things.
We're continuing to work. We are trying to make it easier for families to get homes, make it easier for developers to build starter homes and senior homes, to get the government regulations out of the way there. So because people do feel they're much more comfortable starting their families if they own their homes. And that has been something that we've seen continuously. Then the data checks out there that as long as you're renting, the likelihood of having kids is much lower. And so we want people to put down their roots, feel comfortable building their families and keeping a roof over their head. And we got a very good piece of legislation through there as well, where there's $25 million to be used throughout the state for local governments to be incentivized to cut regulations and allow people to build homes. So that's going to be continuing. And that's not always a pro-life topic, but it is trying to build that full culture of life. And that sometimes just means getting some house keys to people.
I've never heard that stat before, that if you are renting, you're much less likely to have children.
Yes.
That is so, wow, I should know that. Now I know.
Now you know.
And I certainly know that houses are so much more expensive in general here in this city than they were 20 years ago when I first got married. We bought a decent house for like $110,000 20 years ago. And it's like, that's crazy. I don't think you could do that.
Correct.
A nice house like we got at that time.
Right. We've functionally zoned out starter homes. Every new house built has to be, 40-foot setback with 3 bedrooms, 2.5 baths, and like 2 8-foot trees in the front yard.
We
That's
didn't have that.
right. That's not what people need when they're just starting out.
Right.
And you can never have your forever home if you don't get your first home.
Right.
And building that type of equity, building that type of roots in the community and that comfort where people can feel that they're provided for, protected and safe, and then can build their families.
That's so interesting. Anything else kind of in that category of something that really is a pro-life topic, but people don't initially think of that, right, as such, that you want to bring up?
Another thing we did was respecting, it's in the catechism, the first rights and responsibilities to educate children goes to the parents. And the state is supposed to supplement that, not supplant it. And so we increased funding for all of our local public schools, and as well as had our school choice continue and match the funding that's been there for our private school ed choice credits. And that's continuing, as well as for our homeschool families. We moved it from a $250 credit, which you mentioned before is a dollar for dollar. It had been $250 per family, and we moved that to $250 per child, so that those that are homeschooling, like they could be sending their kids to the local public school. We recognize that that's a cost saving for the state. It's also something that parents should have that right to do and be supported in doing that. So it's now $250 per student rather than per family.
Right. That certainly makes a big deal if you've got several children. Sure. We want to encourage people to have several children, right, and their families. Great. Thank you, Representative Mathews, for giving us that, particularly talking about HB 324, right? This common sense legislation of trying to make sure that people are taking drugs that have serious side effects, that they get the in-person consultation to be able to make informed consent and make sure they get the care that they need. So they have the follow-up appointment to make sure things are going okay if they are going to take drugs that could have some serious side effects. Should be fairly common sense, I think, legislation. And then the other legislation that you were bringing up to help families, to help people get houses so it gets started, making families as well. And just sharing your personal work that you do, as you say, your day job with Heartbeat International, and you have 5 children. So you're a fine representative of the people raising families that we want more of here in the state of Ohio. So thanks for taking time to talk with us today.
Of course. Thank you so much. Honored to be here and happy to spend time with you. God bless.
And I want to thank all our viewers and listeners for tuning in on this episode of our Being Pro-Life series. Head to the website to view the links talked about in this episode at www.catholicaoc.org/beingprolife. Thank you again for joining us today. I look forward to being with you next time.